delegates, if you could resume your seats, please. And all of those loitering in the doorways, if you could come in and resume your seats too, please. You're the only people I can actually see. Well, thank you all very much for coming back. Hopefully you had the opportunity to get a little bit of fresh air, and maybe it's not quite so cold as it was earlier this morning. Welcome back to the start of the formal proceedings of the 2016 National Conference. I now call on the Chair, Dr. Bev Robotham.
Thank you, Anne. I'd be grateful if everybody turned their mobiles off for the session. Thank you. I'd like to recognise and thank the major sponsors of the conference, first of all. So, as we've heard, the platinum sponsor is Synapse Medical. The Leadership Development Dinner sponsor, Avant. Our communications sponsor, Amex. The conference sponsor, a new AMA member benefit, Mentone Educational. And the sponsor of the President's Welcome Reception, Aspen Medical. Other conference sponsors, up to date, the National Health and Medical Research Council, Hertz, Palliative Care Australia, the Department of Veterans Affairs, and Clinic to Cloud. And we'd also like to thank our exhibitors, EMPRAC, EBSCO, eClinical Works, and the AMA's member services stand, who will provide you with information about AMA member services. I've got some housekeeping here. There's Wi-Fi for all delegates at the conference. The password required is AMA Delegate 16, all in lowercase, one word. Please let the conference team know if you need any help in accessing the Wi-Fi. We have a social media centre here this year. It's located by the lifts outside the ballroom. I don't know what you would be doing in the social media service centre, but our best wishes go with you. Security and first aid information are available in the conference handbook and on the conference website under general information. And I just need to advise you that the National Convention Centre is filming short excerpts of the conference, and if any delegates have got concerns about appearing in the background or of some room shots, they should let the conference team know. The edited film sections will be only a few seconds long. There are power boards at the side of the room if you need to charge your device. The Wi-Fi and Q&A instructions are on the print sheet in front of you. And CPD feedback forms are available for download underneath the relevant sessions on the conference website, and if you could mail these back to the conference team for points to be allocated. So we'll turn now to the formal business, and the first item of business is the notice of this conference, and the notice of the 2016 National Conference was circulated in the Medical Journal of Australia on the 4th of April 2016. So I move that the notice of the 2016 National Conference of AMA Limited be taken as read, and your voting cards are yellow. I put the motion. Those in favour?
I think we might need lights on this.
Yeah. Those against? No against, so the motion is carried. We now move to the accreditation of delegates, and in accordance with Standing Order 5 of the National Conference Standing Orders, no business may be transacted unless at least one half of the number of delegates eligible to attend is present, or if that is not a whole number, the next highest number of delegates. I note that today there's a list of 140 delegates appointed in accordance with Clause 16 of the Constitution. So I now move that the list of delegates present be noted for the purposes of accreditation of National Conference delegates. I put the motion by a show of cards. Those in favour? Thank you. Those against? The motion is carried. We'll now adopt the standing orders. So the standing orders of National Conference have been circulated in your conference handbook and can be found on page 19. I now move that the standing orders of National Conference as circulated be adopted. Put the motion by a show of cards. Those in favour? Those against? The motion is carried. I'll now ask that delegates refer to page 24 in the handbook or the minutes section of the online version under National Conference proceedings, and I move that the minutes of the 2015 National Conference be taken as read. By show of cards, those in favour? Those against? The motion is, is that? No. All right. So the motion is carried. Matters arising and outcomes from the 2015 National Conference is our next item of business, and at the 2015 National Conference there were 2 urgency motions passed by delegates, and I draw the attention of delegates to a report on the outcomes of these motions on page 33 of the conference handbook. Are there any other matters arising from 2015 National Conference that any delegate wishes to raise? No? Thank you. We now move to motions on notice, and no motions on notice have been received by the due date. So we will now look to the urgency motions. So we've received 2 urgency motions, and I remind you of the purpose of this session. The proposer of an urgency motion has 2 minutes to explain why the matter should be debated. The matter will not be debated at this moment. So the proposer will explain why the matter should be debated, and at the conclusion of the 2-minute period, the delegate will then move a motion that the matter be debated, and the motion will require a seconder and a 2/3 majority of delegates voting in support, and the debate of successful urgency motions takes place on Saturday afternoon. Okay, so the first urgency motion is a lengthy one, and it goes over 3 PowerPoint slides, so we'll move slowly through these so that everybody can take in the substance of the motion. I invite Dr. Harry Hemsley to the podium, and who has proposed this motion, and it's seconded by Professor David Mountain. Harry, would you like to come and read out your motion?
Thanks, Bev. Last night I was kissing my 10-year-old daughter goodnight, and she said to me, "Dad, do you like being part of the AMA?" And I said, "Yes." And that brought up a whole lot of questions to my mind. Why am I a member of the AMA? I find it important. I think it's our duty to represent our organisation and do it well. And our leaders do it well. Our President, Brian L, has done a fantastic job, as did Steve Hambleton before him, and previous presidents before them. But despite that, our membership as a proportion of total doctors in Australia is shrinking. When I took over the presidency in Victoria 7 years ago now, I think it was around about 46% of the total doctors, our members were 46%. Now it's, 34? And there's important cohorts of doctors that aren't members of the AMA. We don't have, they're well represented, mind you. We've got fantastic women representatives, but very few women. We've got fantastic doctors in training, but as a proportion, very few doctors in training. We have very few international medical graduates. And not surprisingly, our numbers of GPs, and I've watched it throughout Australia, keep dwindling more and more and more and more. And that's a concern to me. And though we are a fantastically successful lobbying organisation, one of the strongest in Australia, despite this, our representation as a body, we're becoming less and less representative of those groups. And we need to take a good hard look at ourselves and look at how we can improve what we're doing and become more representative for those people. It could be just a price point. For instance, female GPs. Should there be more than one category of part-time? It could be a cultural thing for the international medical graduates. Are they afraid to be members of the AMA? Why aren't they members of the AMA? Why aren't they joining us? I'm running out of time. Anyhow, I'm quite passionate about this. But so, as I've said, the AMA is a fantastic representative organisation. Now, the urgency motion is as read, and thus what I'm doing is I'm calling on National Conference to call upon the Board of AMA Limited and federal councillors in conjunction with state and territory AMAs to urgently commission a comprehensive review of its operations, and in particular to examine, among other things, the aim, structure, operations, day-to-day functioning, communications, interactions with members, the public and the media, and how we support our members, and its relevance and attractiveness to both members and non-members. I think that's urgent. I've watched our numbers decline over a number of years, and unless we do something about it now, it's just going to continue to go in the direction it's headed. So I urge you to vote in favour of this motion. I'd like to see the Commission to be tasked with reporting back to the Board the federal, state and state territory AMAs and members within a 6-month time frame, with a recommendation and a plan and a vision and determination that will lead to reinvigorating the AMA, becoming more representative and sustaining the AMA into the future. So I encourage you to all vote for this so that we can have a look at ourselves as a federal organisation and get on with being more inclusive. Thank you.
All right, have you all had time to read the motion on the PowerPoint, or would you like it? Do you need to look at it again? It's a long motion, or are you happy?
We're not debating the motion.
No, there's no debate of the motion today. That's just whether or not this motion should be debated on Saturday afternoon. Okay, well, we'll put the motion then by a show of cards. Those in favour of accepting an urgency motion? And we'll need counters. Is somebody doing that?
Okay, could you get the Secretariat staff to count?
How much? 51 and 34. 85. Well, thank you. The motion requires a 2/3 majority to be carried, and the motion is therefore lost. Okay, we turn now to the second urgency motion that moved by Richard Kidd and seconded by Michael Glickman. It's on the screen, and I invite Richard Kidd to come to the podium. Yeah, okay. All right, I'll backtrack. I apologise, Harry. Those against the urgency motion number 1, as put by Dr. Hemley? So the rest aren't here. So it is. All right, we'll now take abstentions. 1, yeah, somebody counting. Eight. 14. They've got 140.
It has to be 2/3 of those present and voting.
But they're not present. They're not in the room.
Yep. So that means of those present and voting, it's more than 2/3.
Okay, so they are. It is passed.
Yep.
Okay, well, thank you very much. That's evidently we've got a lot of people who've something else to do rather than be present at this session. So the motion does meet the 2/3 majority and therefore will be. We turn now to the second urgency motion, and which is on your screens. I'll ask Richard Kidd to read the motion, and then he has 2 minutes to speak to us about why the motion should be debated tomorrow afternoon. Thank you, Richard.
Thank you. The motion is that the Federal Council be requested to look into the matter of the Australian Federal Police conducting surveillance of doctors involved in the healthcare of asylum seekers and refugees. The urgency of this is that, for people who are not aware, it was only a couple of days ago that it hit the media, The Guardian and a number of other publications, that Dr. Peter Young has been under surveillance by the Australian Federal Police for some time. And it's quite clear from some other events that other doctors who are involved in asylum seeker and refugee health care in Australia have also very, very probably been monitored. And for me, who may well be one of those ones that's under surveillance, I'm very concerned because my mobile phone I use to take calls from patients, nursing homes, colleagues about patients. So it's not just my privacy that's been invaded, it's my clinical privacy that's been invaded, the privacy of my patients. And this would be true for all the other doctors that would be under surveillance. And it's gone further than that. Late last year, one of our colleagues, an AMA member, a past AMA New South Wales councillor, came up to Brisbane to brief solicitors on the coronial inquest into the death of Hamid Karzai. Now, while she was up there, she spoke to Dr. Peter Young for about 90 minutes on the phone, And when she came back down to Sydney, no one was allowed off the plane. The Australian Federal Police came onto the plane, essentially arrested her and detained her for well over an hour, during which time they had taken her iPad, her iPhone and her laptop off of her, and she didn't see those items for a good hour. So this is a matter of urgency. This is a matter of why doctors going about their normal work, trying to look after patients and doing some advocacy, can be subjected to fairly draconian invasion of not just their privacy, but also their patients' privacy. So I would be very grateful if this is debated as a matter of urgency. Thank you.
All right, well, we'll now put the motion by a show of voting cards. Those in favour? Okay. All right. Those against? 1. 3. Abstentions? 5. Okay, well, the motion is carried. So these urgency motions will be debated on Saturday afternoon. Well, that concludes the formal proceedings for today, and it's my great pleasure to introduce the first of our policy sessions. This one is entitled Assisted Dying, Exploring Members' Perspectives, and the chair of the session, Dr. Michael Gannon, who chairs our Ethics and Medico-Legal Committee, will chair this session. Welcome, Michael.
Good afternoon, everyone. For those of you who don't know me, my name is Dr. Michael Gannon. I'm the President of the AMA and WA, and I'm the Chairman of the Ethics and Medico-Legal Committee. I hope you're all looking forward to this session today. Those of us in the committee have put a great deal of thought and work into it. Very grateful to Dr. Kate Stockhausen, in charge of the ethics session of the AMA, for helping it put it together. I hope it's going to be a really engaging and exciting session. Thank you for attending the 2016 AMA National Conference and this session on assisted dying. For the purposes of this session, we've referred to euthanasia and physician-assisted suicide collectively as assisted dying. As you know, the AMA is currently reviewing its policy on assisted dying as part of its routine 5-yearly policy review, just like it does with all other policies. If you refer to the outline on this session in your conference handbook, you'll see the current policy in full, along with the clarification of some of the terminology you'll hear today. We've made a very strong commitment to engage with AMA members as part of this review. Late last year, we invited members through Australian Medicine to send us their open-ended comments on the current policy. And more recently, we conducted a survey of all AMA members where we received almost 4,000 responses. This survey is currently being collated and will be considered by Federal Council in the near future. The survey results will be disseminated to members after that, and as such, we will not be discussing the results of the survey today during this session. The next opportunity for member engagement in this area is this session here at National Conference, hopefully providing us with a unique opportunity to have what I hope is an intra-professional discussion on assisted dying, very much doctors for doctors, where we, as doctors, can discuss amongst our colleagues whether or not the medical profession should have a role in assisted dying. The issues raised during this session will also form part of the review and the considerations of Federal Council in coming months. So just some ground rules, as this is an intra-professional discussion, and although we've invited observers to come to this session because of the importance that this issue may have to them, questions will only be taken today from doctors and medical students. The format of the session will be similar to that of ABC Television's Q&A program, and we will similarly be using a combination of pre-selected questions and questions from the floor. There are microphones that you can see standing, and there are also roving microphones that will be coming around the room. Those doctors with a pre-selected selection know who they are, and they will be asked to stand up and read their question out to the panel. We'd like everyone else to stand up at one of the microphones. Please keep your questions short, and please ask a question rather than incur the wrath of Mr. Jones, who might tell you that he'll take that as a comment. We'll do our best to get through as many questions as possible in the 2-hour session. For those of you wishing to make general comments on the issue, we have installed a Q&A system where comments can be written out and projected onto the screens behind me here, similar to how Twitter feeds work on the television program. The instructions are written for you there. Now, please note that the panel aren't reading these questions and they will not respond to them, but it does give an opportunity for people to engage in the session and express their opinions to other people in the audience. Now, I want to make it very clear that our panel members are not AMA representatives and not spokespersons. They cannot answer a question on behalf of the AMA. With one exception, they are Georgie Haysom, who will be giving us some legal expertise. They are individual medical practitioners who have a profile and an interest in whether or not the medical profession should have a role in assisted dying. It is by design that I'm not sitting on the panel. There may be questions from the floor that do relate to the process, but the doctors on the panel are not here to speak on behalf of the AMA. We made a conscious decision to let debate flow freely without the influence that an AMA representative like myself might have had. Finally, I probably don't need to say this, but I just ask that everyone is respectful to both members of the panel and to each other. You all know that assisted dying is an extremely contentious and emotive issue, and I know that many of you in the room have very strong convictions. I'd like you now to welcome to the stage someone who many of you will recognise, if not all of you, and turn over the session to our moderator, Mr. Tony Jones. Tony's one of ABC Television's most respected journalists with more than 20 years' experience in radio and television news and current affairs. He anchors Late Line on Wednesday and Thursday nights. Tony began hosting this award-winning news and current affairs program in 1999. In 2004, he received a Walkley Award for Best Broadcast Interviewing for a series of interviews on Late Line. And as you all know, Tony also hosts the ABC's Q&A program on Monday nights. We are delighted to have him with us today. He will introduce the panellists, but please make Tony welcome. And Tony, I'll leave you in charge.
Thank you very much indeed. I have very little to say except to introduce our panel. Being not a doctor myself, I have to say I'm probably the only person who will be asking questions from time to time who isn't a doctor. But I'll quickly introduce our panel. I'll go straight into questions. I will in fact be able to see comments that are made by telephones. I'll try and introduce those into the discussion as well. So our panel, as they are seated, Mark is the last one to seat, the Associate Professor Mark Yates from Deakin University, and a geriatrician at Ballarat Health Services. He's a former Victorian President of the AMA. Save your applause till the end. Next to him is Emeritus Professor Bob Douglas, a retired public health academic with prior clinical experience, both as a general practitioner and a specialist physician. He's also a co-founder of the think tank Australia 21. Next to me on my right is Ms. Georgie Haysom. She's the head of advocacy at Avant, and a medico-legal expert. On my left is Dr. Karen Hitchcock. She's a staff physician at the Alfred Hospital. She's also the author of Dear Life on caring for the elderly. And next to her, on my left, is Professor Malcolm Parker. He's a professor of medical ethics at the University of Queensland. He was in general practice for 30 years. Please welcome our panel. Thank you very much. There should be a microphone somewhere near our first questioner, Dr. Robert Marr. Will Dr. Robert Marr please stand up? We'll give you a microphone. Thank you.
Thanks, Tony. I've been a GP for over 36 years, and over the last few years I've noticed a reluctance of some doctors to use even the traditional double effect of morphine, etc., at the end of life of terminally ill patients. The reason some doctors give is that they're frightened of being reported by opponents to assisted dying that they may have been involved in voluntary euthanasia. The New South Wales AMA has confirmed to me that several doctors a year contact them with these concerns. I'm aware, for example, of one terminally ill 80-year-old patient of mine who was dependent on an endotracheal tube and who agreed to have the endotracheal tube removed knowing she would die. Unfortunately, the ICU doctor removed the tube without any sedation in front of all the relatives, and the patient suffocated in front of them. When they asked the doctor, "Why didn't you give us some sedation?" he said, I didn't want to appear that I was being involved in voluntary euthanasia. This is a concern that's out there for a lot of doctors, that there seems to have been, well, I believe the discussion about assisted dying over the last few years has created a backlash with those opposed to assisted dying, and this has resulted in some patients in terminal care not receiving the ideal care. I strongly believe it's time that terminally ill patients had the right to request medical assistance at the end of their life if their suffering is too great after receiving the best palliative care. And I think it's time that we considered such models as the Oregon model, which involves self-administration, because this it gets over the problems of doctors administering a lethal dose. The doctor doesn't administer any lethal dose. The dose is only available and with very strict safeguards for a terminally ill patient to self-administer. So I was wondering what the panel thought. Is this Oregon model of self-administration a policy that could be acceptable in the future for the AMA as we consider this issue?
Okay, let's go around the panel. I'll start with Malcolm Parker.
I would agree with you because I'm on that side of the argument, but I wanted just also to go back to what you said at the beginning in relation to that patient, but that doctor. It's widely understood now on the basis of good evidence that, and I don't mean this to be offensive in any way, that doctors' knowledge of the law in all sorts of areas, including this one, the end of life, is not particularly good. In Queensland, there was an act, the Palliative Care Amendment Act, which was passed, which was purely to put into legislation what was already understood to be a common law availability to doctors, and that is the use of the double effect doctrine. But they had to put it into legislation, and even in Queensland, with such legislation, I'm not aware of any other specific legislation, but with that sort of legislation, what you're talking about still exists. That is, doctors and other health professionals are worried that if they do what we call good medical practice by treating symptoms as they arise, even if that has the effect of causing death, then they'll get into trouble. That, of course, is not the case, but doctors still need to be disabused of those beliefs.
Malcolm, I'll come back to you on the question of the Oregon laws, because I think we will discuss that as a key part of that question. But just on that very issue, and I'll bring Karen in on this as well, the AMA's current guidelines do appear to allow for hastening death with suffering patients, the administration of treatment or other actions intended to relieve symptoms which may have a secondary consequence of hastening death. That incidentally goes against some of the principles of palliative care.
Well, no, it doesn't. Okay. That's not true. I mean, what that is saying is that we can use double effect, and double effect is just based on the bedrock of medicine, which is that we treat symptoms. And so I completely agree with you that there is evidence that doctors or some health practitioners are scared to give, whatever dose of morphine because it might stop the patient from breathing. But I think that it's our responsibility to alleviate suffering in our patients, and if you need to give a dose of medicine that does hasten their death in order to treat their symptoms, then that is already legal. But making that clear in legislation is obviously not enough. There needs to be education around that issue.
I have heard many palliative care doctors say it's part of their central principle that they cannot hasten death. Is that not the case?
Well, the issue is not, we never treat life, we treat symptoms. So the whole thing about hastening death is almost beside the point, because what you do is you treat symptoms. And, death is not the cure. Getting rid of the symptoms is the aim. So, yes, they don't set out to kill the patient. We set out to alleviate their symptoms. And that is the aim.
Okay.
Can I just
sure.
quickly say that the difference here is that of intention. So if you intend to hasten death, then you are at risk at the hands of the law. If you don't intend to hasten death, but if you intend to treat symptoms and an incidental secondary result of that is death, then you're okay. Turns on intention.
All right, we've got a legal expert on the panel, Georgie Haysom. What's your view on this and the concerns being expressed by the questioner?
Well, I think what Malcolm just said is absolutely right. It does turn on intention. If you intend to cause someone's death, then that is under the current law murder, and therefore you could be prosecuted. And that's why the law of double effect came in relation to the use of medications at the end of life to reassure doctors. I would agree with Malcolm that it's about education, because this has been around for quite a long time. I think this doctrine in common law and in legislation, and yet doctors and other health professionals are still concerned about the implications of treating patients at the end of life, where it might end up, well, some people may think that it hastens death.
Yeah, I'll go to Mark at the end to hear your view.
Only to add, I agree with everything that's been said. I think it is an issue of education. I think the issue of the question of double effect comes back to whether or not we as a profession are allowed to practice as a profession and that is valued in the community, or whether we want lawyers to try and wrap up these very, very complex decisions in particular pieces of law. The AMA is very clear about its policy in relation to double effect. Good medical practice is a very safe and well-defined entity in legal constructs. And the double effect is available and is used on a day-to-day basis in practice because we are trying to treat a patient's symptoms. Therefore, the concept of the Oregon legislation becomes irrelevant in that environment. And I think the issue for the AMA is clearly about promoting good palliative care, understanding the existing legislation, and a lot of this debate, which has been driven by a small number of people with a particular interest, and their deep-seated interests and concerns, I understand, we'll be better off as a profession doing that.
We'll come back to as I said, to the Oregon laws, and they've been raised specifically, so we will do that. But I just want to hear Bob on the first part of the question that we've just been discussing.
Well, I think the double effect is a nonsense, and I think it's become quite clear that it's causing serious concerns for many doctors, and I think the questioner has made that point. But I think it also is a concern for the community. The community is absolutely united on the view that they believe that we should not treat our community worse than we treat our pets. And the community is at a point of saying we believe that it should be possible for an informed person to request death and have help from the doctor who's treating them, who's there not just to keep them alive, but to manage their concerns. And so I think the doctrine of double effect is simply a legal circus around the problem that we have because we haven't enacted sensible legislation.
Okay, just hold on, everyone. I'm just going to bring in, there's a comment that's come in. I'll try and bring these in from time to time. This one's from Kyle Sheldrick. Why is paternalism taboo in all other aspects of medicine, but we deny any role for patient choice in choosing to die on their own terms? Karen, you wanted to come in. You might like to respond to that.
Well, paternalism's not taboo, really, when it comes down to it. We just pretend it is. And we don't deny any role for the patient to choose. I mean, that horrendous example that the questioner gave us of a woman who chose to have her treatment withdrawn, which every single patient has the right to choose not to have a treatment, so she wants her trachea out, and we know what the result of that is, that she's going to suffocate, and the doctor neglected to give her, you know, we have an ancient treatment that will mean that she doesn't feel that and her family doesn't have to watch her choke to death, and that was withheld from her. And I think her right was to have her symptoms treated. Her right was to have her treatment withdrawn. It's not her right to say, kill me. I mean, that's completely different. And where people do have the right to end their life when they want, suicide is not illegal. But what we're asking for is a right to kill, that is a right to give doctors, you know, the right to kill, and a right to demand to be killed. And both of those things, I don't think that we have that right.
Okay, that's actually a perfect segue in a way into the Oregon laws, which were canvassed by the question. And I'll go to Malcolm first on this. The Oregon laws are interesting in that the doctors are at arm's length. The Oregon laws, incidentally, are about to be taken up in California too, so another 38 million Americans will be under the same kind of laws, but they actually give doctors the right to opt out of the system completely, and when it comes to their involvement in the system, it is about prescribing, not administering. In fact, they're prohibited from administering. So I just wonder if that makes a difference. Malcolm first.
I think that makes a difference. I think it's intuitively more appealing, even to people who oppose the legalisation of euthanasia, to use that single word, that physician-assisted suicide be legalised. So if you were opposing it, you would say, okay, well, that's better than the full Monty, as it were, the lethal injection. And that is because right at the end point, the patient still has control. To pick up the point about paternalism and patient control and patient autonomy. So it is more intuitively appealing to legislatures, to doctors on the whole, I think, and probably to the population. So the Oregon model, the Washington model, the California model is different, of course, from the European model, where both physician-assisted suicide and lethal injection or other lethal means are lawful.
So do you think the Australian public would be prepared to accept, given the overwhelming, in terms of opinion polls, the overwhelming number of people who want some form of doctor-assisted dying, only according to opinion polls, I hasten to add, do you think they'd be prepared to accept a kind of halfway house, which is what Oregon and California represent?
I think they'd be more prepared to accept that on a population basis. Putting that another way, it'd be more likely through the political system, through the state parliaments, to get that sort of legislation through than the double whammy.
It's just preposterous. If I write a script, I take responsibility for giving that medicine to the patient. A script is a recommendation. I don't, obviously a patient has a choice not to take it, but if a doctor gives a patient a script, they're saying, please take this warfarin, or, you know, this is my recommendation to you. And if a patient comes and says, I want to die, I don't say, well, it's up to you, here's the script, take it or don't take it. I mean, it's just, I think that's, if you think double effect is preposterous, then the idea that somehow the doctor's responsibility, or that giving someone a script is not an act, is equally preposterous.
Look, can I quickly say I couldn't agree more with what you said. What I said was that it would be more likely on an intuitive basis that this halfway measure would be passed by a parliament. But I couldn't agree more with you, Karen. I don't see any moral difference whatsoever between the lethal injection and providing a prescription.
Let's hear from Mark at the end.
So, take your own words. I mean, so if it's a halfway house, where's full house? Because I think that's the real question in mind. So what is the AMA trying to achieve?
You asked the question, so I'll explain what I meant by halfway house. A full house is a doctor administering the medicine or the lethal dose, as in Canada or the European models. Halfway house is at arm's length. That's what I was thinking, just to clarify.
Okay, so that would include then the both the Dutch and the Belgian model, where potentially existential suffering could be included. So the example of the man with early dementia, which is close to my heart as a geriatrician, was able to convince whatever process they had that it was reasonable for him to take his life, that under the Gurin principles, that it's quite reasonable for children to also receive euthanasia, which exists as well. I understand the conditions were for terrible skin conditions, but these are the realities of the full house. So that's where we're talking about. So my question is, what is it that the AMA is trying to achieve? I think we've got to actually realise that this is a debate about advice to a federal council in a membership organisation. And if we're interested in anything as an AMA, according to our strategic view, and that is to actually achieve a better health for those in the community. I'm just wondering why this extensive debate about a small piece of legislation around euthanasia is taking dominance over an extensive and important debate about better palliative care and the introduction of good and widespread use of advanced care directives.
Reasonable question. Bob, before I bring you in, I'm just going to bring in Georgie because you're obviously here as a lawyer and you actually have looked at the various laws and the differences between them. So since the Oregon law was raised by that question, what does it mean for doctors in Oregon and now in California?
So the Oregon law has some quite detailed requirements, and actually some of the requirements are quite similar to the Rights of the Terminally Ill Act that was passed in the Northern Territory 20 or so years ago, which of course we all know was kind of made ineffective by some federal legislation. So the interesting thing I think for doctors is that there's quite a few safeguards in the Oregon legislation. No one can be compelled to, as we mentioned, end someone's life through a lethal injection, so it certainly doesn't deal with active euthanasia, using that terminology. And no one can be forced to participate, no healthcare providers under any duty to provide physician-assisted suicide. So there's those sorts of provisions in here.
Which is effectively an opt-out clause.
Yeah, that's it. Hospitals can't be forced to participate in this legislation. So there's those sorts of safeguards for those who don't wish to be involved. And for those who do wish to be involved, then there's immunity from prosecution and liability and disciplinary action if they act in good faith and without negligence.
And Bob?
So the doctors are safe. What about the patients?
Well, let's hear from Bob first.
Well, can I comment on the patients? I think from the perspective of the patients, and I'm getting close to that point, closer probably than the rest of the people on the panel, and my concern, as I think is true for millions of Australians, is that when I get to that point of incurability and inevitability, I don't want to put all my relatives through the pain and suffering that will come from an elongated process that is quite unnecessarily elongated. And I recognise there's various permutations of the way that might be terminated, but it does seem to me that the Oregon approach is likely to give a lot of people comfort to know that it is possible to have a prescription given by the physician that can sit in the locker that you can take at the point you want. And it seems to me it's absolutely ludicrous that we prevent that from happening in Australia at the present time. We make the possession of Nembutal a felony or a crime, and yet that is exactly the sort of reassurance that people want. And for so many people who have that in Oregon, I think it's about 2/3, they won't use it. But it is part of the sense of reaching the end of their lives that they seek and would like to benefit from.
It is true that 33% of the very small number of people who actually take advantage of this law end up using the lethal dose. That is true. But Mark wanted to jump in.
So 2/3, actually, with appropriate support and sharing of their suffering and anguish, would actually not have even wanted it in the first place.
I don't necessarily think that follows according to Bob.
Well, I think that's debated. So again, we go back to this question of what it is we're trying to achieve as an outcome, and as Levi Miller said Neil Levi, from Macquarie University, and I think it's a very important thing, is this question about, is choice a freedom? Choice is never a freedom. Choice is actually a burden. I don't know how many of you have had to choose what mobile phone number you want, what ring you want on your mobile phone. It's a pain. And I think that in fact there's a real risk, and I think we're talking here about concept of going to the Oregon legislation without talking about the elephant in the room. And the elephant in the room is, what is our role as a profession? It's all well and good for the public to say, yeah, doctor, you're going to help me die, or you're going to kill me. But we're the ones who have to actually carry the psychological burden of that. Now, there are some in the room who probably say, yeah, no worries, I can do that, that's fine. Okay, fair enough. But this is a profession we're talking about. We have a capability as a profession. We are in this space all the time. As a geriatrician, I am in this space every day, working with people who are diagnosed with dementia, who face all these sorts of difficulties, and we share them together. And I want to be able to deal with those as I can share that.
As a matter of principle, would it worry you if some people opted to do that and others, such as you, opted not to, which is, of course, the right under the California-Oregon laws?
My issue here is that, in fact, the question in providing the option, providing the choice, I'm actually applying a value to that life. So if they were to say, I've got dementia and I know that in the next 8 years I'm going to become dependent, right? Therefore, there's a cost to the community. Now, if I've got choice, so then surely my choice is now if I choose actually to go on and be a burden in someone else's mind, not my own mind, to the community, therefore that is applying, I'm now applying a burden. If there was never any choice, this is my life. So therefore, if an individual...
Very briefly, as a matter of principle, you would oppose other doctors having that option to prescribe, whereas you would obviously opt out. You would object to other doctors having that right. Is that correct?
I think, as a profession, we have to give some direction in our community to these particular principles, okay. And I would think that would be inappropriate.
Okay, now that actually brings up the issue that you raised before as to the AMA's role in this, and so a question has come up on the Twitter feed. I'll just read it out. It's from Corey. I believe that assisted dying will eventually be legalised, but I do not believe Australia is ready for this discussion. And I don't think the AMA can currently have a unified view on this. Malcolm?
Well, if we're not ready for the discussion now, we never will be, because we've been having the discussion for the last 20 to 30 years. So I'm not quite sure what the commentator's driving at there. I mean, if you think of the history of the debate, the discussion, a number of areas of the debate have really been moved past, I think. And perhaps that's one of the reasons why we're talking here today. We're talking about both the euthanasia question or the assisted dying question, but we're also talking about the question of, to put it this way, even if the community passed legislation to allow for it, the second question is, should doctors be participants in it? And I think they're two discernible questions. But we have certainly moved past a number of areas of the debate which were very heatedly discussed 20 or more years ago. So, for example, the distinction between actions and omissions. And if you go back to Robert's question about pulling the tracheostomy out, was that an action or was that an omission? It's quite possible that a court, if that case was brought to court, would look at that as being an omission or a removal of burdensome treatment, and there would be no criminal cost to pay. But I would challenge you to think about that. Where does your intuition lie in relation to that action or omission? What is it? So this action and omission distinction, on which a lot has turned, I think both sides of the debate should concede has been sort of left in the past, and we've now moved on to other areas.
That actually, we've got a few people lined up. We've got one person lined up at a microphone, but just before I come to you, sir, just before I come to my one person lined up at the microphone, we actually had a questioner that had a question related to what you just said. I've got it on my list as question number 5, and it's Dr. Lawler Smith. Dr. Lauren Lawler Smith. Is Dr. Lauren Lawler... There we go, we'll get a microphone to you quickly. And after that, we'll come to you, sir, on the microphone. Thank you. Would you mind standing up, Lauren?
Why, if the AMA has a deliberate policy of neutrality on abortion, which some doctors morally oppose, does the AMA think it appropriate to have a policy opposed to voluntary euthanasia, which many doctors morally support?
Okay, we'll start with Karen.
No, I'm nothing to do with the AMA. I don't know why they feel the need. Is that what the question was? That's an AMA question?
Actually, it wasn't the question that I was expecting. I think Lauren must have more than one question, as a matter of fact.
I don't know why the AMA thinks they need to. Do you want to answer?
Yeah, okay. Look, that's fair enough. Lauren, do you have your other question? It says about the logic behind supporting rational choice. I'm sorry about that.
What's the logic behind the AMA supporting the rational choice of an informed patient to refuse life-supporting medical treatment or to request the removal of or turning off of medical equipment, but not supporting the rational choice of an informed patient who requests medical aid in dying? The end point is the same. The patient's wish to achieve relief by choice of death is satisfied.
I'll start with Mark, and although he's not in the AMA, he was once. Not officially the AMA, he was once, so you definitely have opinions on what the AMA should and shouldn't do.
Well, I don't think I can quote, can't speak for the AMA, but let's talk about this issue of intent. And I think the law actually indicates that these are completely different things anyway. But I mean, in a simplistic way, I guess the point is that I think as doctors, we're here to assist patients and families to cope with the fears and anxieties of a patient who is dying. That is when death is on the threshold and already opened the door. And that's what our key role is, and that's why we're healers. I think also medicine and science has also unfortunately given us the ability to build a fire door at the hall and a portcullis at the dining room and double locks on the living room and actually a double door on the bedroom. And so, you know, we in the hope that death might get bored or walk away. And I think that if any of us are in practice, any of those of us who are in practice, and interestingly, a lot of the calls for euthanasia comes from those who aren't in practice, or certainly those who are at the interface of this particular area, would say is completely different taking out an endotracheal tube of a patient with chronic obstructive airways disease in ICU and supporting them while they die. And that's a completely different thing than saying to someone with mild dementia who says, I don't want to live for the next 8 years. Yeah, come on, we'll arrange so we can actually extinguish your life.
Bob.
Well, I don't think I think I disagree with Mark on that.
Sure you would.
I do think that for many people, they can't make the distinction that you've made, and I think the law, as I said earlier, is an ass on this.
That's why we're the profession, Bob.
We're
the profession to help. That's why we're the profession. I mean, we get paid $200,000 a year to make these sorts of decisions. That's why the community gets it wrong.
I see. So 83% of the community has got it dead wrong.
Well, you've got to ask the question.
And
Mark, I think you better let Bob waited patiently for you to make your answer, and I think you probably should hear him out.
We, the professionals, know better and can make this crazy distinction. To my mind, the problem is that this distinction has been, you say it's the law. The law is made by the community and our representatives. The community is demanding or requesting that we change this. It's not happening, and something's happening that organisations like the AMA are standing in the way because they think they know better. For God's sake. The problem is clearly that a lot of people get to the point of seriously feeling they want to end their lives. Now, it's true that they may change their minds. It's true that they may be depressed. It's true that there may be a lot of other factors operating. But a significant number of people feel that unless they can have that possibility, life is seriously troubling to them. And I don't think all the professionalism and pretense that the medical profession makes that it knows better is good enough for the community at large.
Georgie, I'll just bring you in on the pure legal question. So effectively it is legal to take someone off all forms of treatment and to allow them, even in palliative care, to starve to death. But it's not legal to hasten their death. It's not legal to give them medicines which kill them, even though they ask for it. So is that as clear cut as that?
Well, I wouldn't say starve to death, and I think probably the doctors would probably, a lot of doctors would object to that emotional terminology, but I'm not a clinician, so I won't go there.
So
it's the withdrawal of artificial
what
fluids and
happens when
fluids.
you stop feeding people?
I'm not a clinician, but generally I think the general accepted phrase is around withdrawing food and fluids or withdrawing artificial feeding and nutrition. The law is, I think...
So I'm really sorry, but I just actually want to say one thing here, because I think many people in the community have this Hollywood idea about what it is to die. You know, dying at home means you're in your own bed, beautiful soft pillow, and you close your eyes and turn your head and all your loved ones are around with candles. Really, it is quite a natural death, in inverted commas, whatever that is. If you're 96 years old and you manage to avoid hospital and your organs slowly shut down, you stop eating and drinking and you slowly die. It's not when we feel hunger, it's painful. When someone who's dying stops eating and drinking as their organs go quiet, it's not a painful state of active desiring for food and drink. It's, in fact, you would dehydrate to death before you would starve to death. It doesn't take very long, and there are natural bodily processes that take over. And it's
how long does it take, actually, Karen? I mean, is there is there an average?
You can't go without water for more than a few days. I mean, how long can you go without water? Not very long. It just takes a few days, and it's not some terrible, you're lying there like this. I mean, I hear it all the time in the media, people starving and dehydrating to death, and, you know, it even makes me feel scared. There is so much fear out there. There is such a lack of good palliative care training and education, and we need to start there at least before we start going, oh, let's go in for a clean kill. I mean, it's just really, this can get so emotional, and I'm so sick of TV shows because this makes great TV. You never ever see any documentary show running you through a family whose family member is in hospital having an excellent palliative care-led peaceful death. Never would you see that, because it's just boring, isn't it? I mean, what you want is terrible stories of suffering and drama, and they do happen. That's the shame for us, and we need to take responsibility for that and really pick up our game, because the public is really scared, and that's why it's become so emotional and such a big issue, which really, if we had good palliative care, it's not. The euthanasia question is not one question either. It's many things. The situation of somebody with metastatic cancer in the last days of their life in unbearable pain, that's one question, and really that's the only thing that legislation will be made about. Then there's the next question of whether people with neurodegenerative diseases, should they be allowed to have euthanasia? I mean, that's a completely separate question. The first question, I think, is simple, because if there's access to good palliative care, and then the patient's symptoms can be treated. The second issue of any sort of neurodegenerative disease is a completely different issue, and I don't think anyone in Australia is yet saying that people, with early dementia should be allowed to kill themselves. And the third part of euthanasia is when you just feel that your illness is going to go on for years and you're going to be a burden to your family, and you should be able to ask your doctor to kill you. I mean, suicide is a really big issue amongst elderly men and young men, and for some reason, whenever an old person kills himself now, we go, oh, that's why we should have euthanasia. But if a young person kills himself, it's like we're saying, well, obviously the old person would want to kill themselves because their life's not worth living, is it? I mean, as if they can't be feeling despair, worthlessness, pain, fear, loneliness. My view on this issue is not based on religion. I'm atheist. It's not ideological. I am completely far left progressive and am amazed that the progressives are all pro-euthanasia. It just comes from my experience of working in a general medical ward for the last 12 years, looking after the oldest patients, the drug-addicted patients, the dispossessed, the homeless, the most vulnerable people in our community whose lives are extremely painful and who very often feel that life is not worth living and that their life is intolerable, and they come for help. And if they have the option of coming and asking for me to kill them, they will. My job is to say, why do you want to die? What can I do to make your life better or bearable in some way?
Malcolm, on the principle that you never interrupt a brilliant monologue, I didn't interrupt Karen for a moment, but she did raise a whole bunch of issues. But let me take you right back to the question, which was about whether there's some sort of disconnect between the AMA's position or the general position that you can take people off medical care and hasten their death, and allow them to go to their death, take them off food and water, but you can't give them an easier, quicker option.
Well, I think, and I'm sure that Georgie can supplement this or give a better account than I can, but the law historically recognises intention, as we've already discussed before. And so if you intend someone's death, then, as Georgie pointed out, that's tantamount to murder. But the law also recognises the fact that omissions can lead to death, and the law is peppered with indications of where omissions to do all sorts of things can be met with criminal or other aspects of legal sanction. So again, we get back to this acts and omissions distinction. So if you... the distinction, and I think a lot of doctors take this to be the case, if you intend to cause death, that's unacceptable. It's unacceptable professionally, medically, and so on. But if you intend to remove burdensome treatment, that's okay, because if you didn't, you would in effect it would be tantamount to assault by continuing the treatment. So the law has historically recognised that distinction, but it's also recognised that omissions can cause all sorts of trouble and get people into all sorts of trouble. So I would conclude from that we're at a time where we can look, where we should look at the law and say, well, acts can be culpable, omissions can be culpable, depending on the circumstances. And the crucial fundamental issue is not whether you're withdrawing burdensome treatment or killing someone, is just burdensomeness per se. And if you are in a position where there's no treatment to remove, then you still can be in a burdensome situation where the only option to help you, if you want to end your life, would be active assistance.
Okay, what I'm going to do is go down to, we've got a few people lined up to ask questions now, which is good. None on those microphones on either side, I might add. Go ahead, sir, your question.
Can you hear me? Yeah. Chung Si Yong, I'm a psychiatrist, and I've been, like Mark, a previous AMA office bearer. But I wanted to sort of ask a question to the panel, I think, which might answer one of Mark's questions about why we're here and why is the AMA interested. And I think my question is about, whether you think if the role of a doctor in relation to their patient changes because of some kind of legal ability for doctors in some circumstances to cure their patients or to help the patients die, what do they think how that will affect the way in which all of us, whether we take part in this or not, are going to be seen by our patients. And I say this because I'm one of the doctors who every day I see people who are asking to die or have tried to die for all sorts of reasons, mostly not to do with a medical illness of some kind. A lot of it's to do with life circumstances. And what I certainly know is that most of those people might be suicidal at one time or another, but they're not suicidal all the time. It depends on what else is going on in life and what other things they have. So who am I to say, when they come to see me at a certain time, whether things might be different for them the next day or in 6 months' time or a year's time? So I feel this is really difficult.
Okay, I'll draw you to your question because I think we've got the gist of it now.
So the question is really, if this were to come in, how do you think the view of the public and patients in general would see it with the doctor? The doctor at the moment is a position of healer. It's quite clear when I see patients that I'm there to try and help them with their life and to keep them alive and to help them with their illness. Now, if I also have the power and I misuse that power...
I'm going to have to take the last part of your question as a comment. You've finished your question, I think, and then you're making a point, which I guess some people on the panel... I know Mark, for example, has a strong opinion on this. If you don't mind, I'll go to the panel and start getting their views. Mark, go ahead.
Do you want me to start? So I think there's two questions that was asked. The answer to the first question is yes. I think that if as the AMAs, if as the profession, we turn around and say it is okay for doctors to kill their patients, it will fundamentally change our relationship as a profession with our community. So that's the answer to the first one. The second question is about adaptation, and I'd urge you all to go to a YouTube and look at B.J. Miller, who's a palliative care physician at UCLA, and he talks about suffering and adaptation after he was he was electrocuted and lost his arm and both legs, and went on to be a doctor and a physician, and a palliative care physician. Because adaptation is a huge part of this, cooling off periods, etc., are all built in to the Netherlands and Belgian legislation. I agree with that. But the fundamental question that drives your popularity polls in the community are not about things that can be cooled off, but are about good management of my mum dying in the next 6 months. And no legislation is going to change that, but good palliative care, understanding advanced care directives will. But if we change the legislation, we fundamentally change our relationship with the community. So we should up palliative care and not change our particular policy.
Bob.
I understand the question. I understand fully that you are in a situation of being a healer and you're concerned that that we will change the label of the profession to being something different. That hasn't happened in Oregon, and it needn't happen if, in fact, you adopt the position that Rod Syme adopts, that a physician is there to help alleviate the suffering of his patients. Often, or infrequently, that suffering can only be alleviated by death. It seems to me that is a perfectly rational part of being a doctor, to alleviate the suffering of people who have been through a series of safeguards and we haven't talked about safeguards at all, but it does seem to me that there are a whole range of safeguards that are in place in a number of jurisdictions, and in Oregon they've been there for 12 years. So I hear what you're saying, but I think that there is a concern in the community that there has been a complete takeoff of healing to the detriment of suffering.
Now, Karen wants to get in, but if you don't mind, just want to ask Georgie, put your patient's hat on for a moment. If you feel comfortable in doing that, well, eventually you will, if you're not at the moment. Be a patient. At some point you'll be a patient. Do you think that would change your relationship with your doctor if you knew they had this ability? It's a personal question.
Yeah, it is a personal question, and I promised myself and others that I wouldn't give a personal opinion, so I won't. But what it does raise, Chung Su's question raises a really interesting question, I think, as a lawyer, about the role of law in society and whether law reflects society or whether law sort of imposes itself and imposes moral positions on society. I don't know the answer to that question, but I think in relation to the question about you were talking about the difference between withdrawing and withholding, and there's a whole...
Yeah, sorry, I meant to come
No,
back to
that's all right. There's a whole heap of, Malcolm will know it well, no doubt, the philosophical discussion around acts and omissions and whether they're philosophically equivalent. But I guess the role of the law is to draw a line where society says that this is acceptable or not, and I think that's what they've done in relation to the law's done in relation to withholding and withdrawing treatment. Said this is acceptable, but going further than that is unacceptable. And so I guess it just has a role in working out a framework within a broad sort of spectrum of behaviour.
All right, Karen wants to come in. Karen, I'm just going to read a comment that's come in from the floor again, and I'll come back to the floor for actual questions. This is from Dr. John P. Woodall. As a country doctor, I can confirm a high proportion of doctors do not have the confidence and or competence to adequately relieve suffering, including the imperative of adequate analgesia. It is not the fundamental cause of and motivation for efforts supporting euthanasia. The lack of understanding the fundamentals of care at the end of life is not the fundamental cause of and motivation for efforts supporting euthanasia, the lack of understanding the fundamentals of care at the end of life, to read that with a proper emphasis.
I would agree with that. I think that's absolutely true. I think people are really scared. And, you know, I just want to say one thing about 80 whatever % of the population of Australia allegedly support euthanasia. What 83% support is an answer to a question in a survey saying that if you are in unbearable pain, in a terminal phase of a terminal illness, do you think physicians should be able to assist you to die? And the answer is yes. I mean, you can manipulate the question and get the answer. I mean, probably I would say yes to that, but that doesn't exist. I mean, there's always going to be an increasing dose of pain relieving medication you can give. So it's sort of everyone saying over and over, oh, the entire population of Australia agrees with euthanasia, is just complete rubbish. To what I think that it's a really big risk what you're saying, and what we're talking about is drafting legislation that determines which lives are and which lives aren't worth living. So when all of your patients come to you and say, I want to die, you do your best to help them live their life. All of a sudden we're going to be saying, like, how do we triage them into suicide? And, you know, these people can commit suicide and these people can't. I mean, we're going to, as, you know, talk about paternalism, we're going to decide together, the lawyers and the doctors, which life is worth living and which life isn't worth living. And I just think, you know, where do we draw the line? It's going to be arbitrary, and it's not a line, it's a cliff.
Okay, Malcolm, I'll bring you in, and I'll bring you in with a comment from the floor, because it's again relevant to the issue of the role of doctors. Legalises from RC, legalise assisted dying if you wish, do not involve the medical profession. You do not need a doctor to die. Task substituted to a defined identifiable other, in inverted commas.
Yes,
so I suppose there'd be some government department which would distribute Nembutal to people who warrant it.
You could privatise it.
bring on the deaf nurse.
There's a couple of comments that I can make there. Quite a number of years ago, there was a sort of a small flurry of articles in the literature along this line, which suggested that there ought to be sort of a subspecialty, not necessarily composed of doctors, but doctors could become part of it, and they would be known as thanatologists. The second comment, of course, is that generally speaking, doctors, the tasks that doctors do, they are being relieved of some of them, and some doctors feel threatened by that. Nurse practitioners, etc., etc. So the comment, I think, is not a flippant one. How you would go about that, I'm not sure. My view is that wouldn't run. One of the reasons for that is that some people are capable of committing suicide. Let's assume that the legislation is in place. Some people are capable of committing suicide, so they might go and commit suicide if they view their life as no longer worth living. But not everybody is capable. And so there's a small proportion of people under any legislation who will need some kind of assistance. And can I just add one brief comment there, taking up Karen's last comment about the value of life? Because I disagree very strongly with the idea that we can, the whole concept of triaging patients, your life is worth living, your life is not worth living. It's not up to the doctors to make a decision about whose life is worth living. Patients who ask for assistance to die, everything else being equal, they're the ones who've made the decision about whether their life is worth living. And some people come to that decision, well, my life, to me, is no longer worth living.
Yeah, like lots of 18-year-old males, for example. I mean,
Well, it's surely not beyond us to discern between certain categories of cases, such as 18-year-old males who may have some kind of mental disorder, and elderly, or even not elderly, people with chronic illness, severe illness, and the usual end-of-life situations that we're really talking about.
So let's go back to patient autonomy then. Yes. Because ultimately, if this is about patient autonomy and choice, we've just accepted that an 18-year-old doesn't have that autonomy or choice because doctors will say, oh no, I think you're feeling a bit depressed and we can make you better. But somehow it's okay for an 80-year-old who has some mild dementia and multiple chronic diseases who says that to just ignore the fact that we would say to them, no, I think actually we can make you a whole lot better because in fact, if we actually got you into some supported care and there was an environment that you enjoyed, you had purposeful activity that was relevant to you in your current cognitive condition and you could enjoy life, which you can, oh yeah, we won't do that because you can have suicide.
That's fine.
So we're not allowing autonomy. So we don't allow autonomy because even under the Belgian and Netherlands legislation, you need two doctors and somebody else to say whether or not you can or can't. Sadly, it's all assessed retrospectively, so it's not done in advance.
Okay, let's just bring it. You mentioned, once again, the legal issue comes up, and I'll bring Georgie back in on that score. What safeguards are there against someone going along to a doctor in Oregon and in the future in California and just saying, I want to die, I'm just so unhappy with my life, will you agree to allow me to die and give me the medicine?
So the legislation has a few requirements. So you have to get a second opinion. Interestingly, the Oregon legislation doesn't have a requirement of a psychiatric or psychological assessment, whereas the Northern Territory legislation does. Well, yeah, I mean, it's still on the books. It's just made ineffective by the legislation, so it still exists.
Is it the case that in Oregon, if one of the two doctors, independent of each other, decide the person has an underlying psychological condition, they call in a psychiatrist?
That's it. So that's where it comes in the Oregon legislation, but they have to. The attending physician has to come to a view that they may be suffering from depression, whereas the Northern Territory legislation made the psychiatric assessment mandatory. And there's other things. They have to be an Oregon resident, so we can't have people coming from other jurisdictions to take advantage of the legislation. They have to fit the criteria of terminal disease. They have to give informed consent. Another interesting difference is that there's no specific mention in the Oregon legislation of the requirement to advise about palliative care, whereas that's in some of the other legislation.
Someone, incidentally, asked a very simple question on the feed here. It was, what is a terminal illness? Bob, is it obviously something that would be absolutely critical? So you have to define it under law, what it is. In fact, under the Oregon, California laws, you have to have doctors define that you are within 6 months of death.
I don't know that I'm the right person to answer that. I haven't had to do that for a long, long time. But I think it is, clearly, it's part of the medical sphere to attempt to develop a prognosis, and doctors give prognoses all the time. Clearly, somebody who's got terminal cancer disseminated through many organs and is deteriorating and so on, and has not responded to chemotherapy and radiotherapy, that may be an example. There are plenty of other examples, and I'd sooner leave it to the more active clinicians.
Yeah, we're not bad when it comes to advanced cancer in prognosticating, but we're pretty hopeless when it comes to everything else, and certainly we couldn't bring it down to months. And interestingly, in Oregon, something like only, I think, 15 or 20% of psychiatrists, when asked, said they could confidently exclude a mental illness in patients requesting assisted suicide. And so that, it's not like these things are clear cut at all. I mean, only 20% said that they would be able to confidently exclude. So I don't know if anyone saw the documentary, I think it was on Dateline, is that the SBS documentary last year, about a journalist from Australia going to Belgium and went through a few patients' cases of where they requested euthanasia. One woman in particular, in her 80s, living in a low-level care facility, perfectly sound mind and body, requested to die. Her GP saw her, got another GP to see her, they both agreed she should die, and so gave her the medicine, she drank it, died on camera. Most shocking thing I've ever seen, and I've had, I've seen hundreds of patients die. And she, turns out her daughter was run over 3 months prior, and she was in a terrible grief state. But the doctor supported that, that grief state was a reason to die. And that case was the first case in Belgium ever to be investigated. So obviously their checks and balances are, good, because everyone says they are, and obviously Belgium doctors are perfect.
So can we go back to safeguards?
Okay, speaking of perfect doctors, we've got a very perfectly polite doctors all lined up at the microphone here, so I'm going to bring them in. People have been jumping the queue like asylum seekers or something by getting on the Twitter feed.
Tony knows who I am. Richard Kidd, I'm a GP, and one of my other hats in life has been doing a lot of palliative care in the community, in people's own homes, hospices, aged care facilities. Probably palliated thousands of people, so a brief comment about this. And just in the last couple of months, 18 in nursing homes and 2 in their own homes. The point about this is that on this palliative journey, which has sometimes been years, existential crises have been one of the things that I've been privileged to help people work through. And many people who have, at the beginning of their journey, said that they want to die, they want to be killed. When that's been explored, there has been a number of issues that when they have been explored and resolved, the person has then approached their death with peace that they didn't have at the beginning. They were tormented when they first had the diagnosis and had all sorts of unresolved issues. So my first comment is just that a good palliative process actually allows many, many people to resolve their existential crises and repair broken relationships with the people they love. The second point is that a lot of the people that I've experienced that have asked that question earlier in the piece, it's come out of fear of what the dying process will involve.
Fear of pain as well, Richard?
Yes, fear of pain, fear of loss of dignity, pooing in their bed, those sorts of things. And yet many of those have ended up being palliated at home with their family, with domiciliary nursing services coming in, and they have had a really good death. And the family have been absolutely pleased that they have been able to be part of that process with their loved ones. So that's the comment. The question, it's kind of been partly answered already, goes to what it will be the unintended harm of opening the door on euthanasia and physician-assisted suicide. And I just add there that when you're talking about numbers, 85% of Australians actually want to die in their own home, not be killed in their own homes, but die in their own homes. And good palliative care is what we really need. But
Okay.
my question is unintended harm, if you could please explore that.
Yeah, Bob, we'll start with you.
Well, the unintended harm is clearly that sometimes we'll get it wrong. I know that others on the panel will say the unintended harm is that we're going to embark on a slippery slope and expose everybody to the possibility of an unintended death. Now, the point about this is that hasn't been the experience in the countries that have legislated in this way. It seems to me that we keep on throwing up these possibilities, and I totally agree with you that we need to invest heavily in advanced care planning and in good palliative care. That's absolutely central to the last years of life. But there's a lot of people in the palliative care community, including my colleague Ian Maddox, who participated in the round table that I chaired on this subject, who has said that the palliative care people have seen this as an insult to their capacity. He adopts the view that euthanasia and assisted suicide should be decriminalised.
He's in the minority, actually.
Well, he may well be in a minority. I don't know, and I'm eagerly looking forward to seeing where the AMA as a body comes out. My understanding was that recently it's been about 50-50 across the profession in favour. So I want to add that I think the role that AMA plays in this is absolutely crucial. I do hope that the AMA will take a more neutral stance than it's done in the past, and that it will enable the community and to move ahead and work out the safeguards that we know are working in many countries already. And as I say, we've now got 12 years of experience in Oregon.
Let me bring in Mark, and Mark, I'll bring you in, I guess, with a bit of a reminder of one of the points that's actually in the current AMA position statement. There are some instances where satisfactory relief of suffering cannot be achieved. This is in relation to palliative care. I suppose the argument often does revolve around those extreme cases, because in those extreme cases you get families, as we've seen, you saw on Lateline the other night, Shane Higson, whose mother died over 15 days in an extremely painful way in palliative care. Those families often become advocates for a change to the law.
And I think those examples are very distressing, and we have examples in medicine where we have incredible cures, which are also fantastic. And then we have these very, very complex issues where there is the small number of people. Now, the issue is that, first of all, I think each of those cases is very difficult to understand in a media sense. So I've got no knowledge of the true environment in which that occurred. I've got no context as to the length or the issues that were being addressed with the family during that time. And I have no idea also about what decisions were made along the pathway to that death that might have actually been a more sensible decision earlier if we had proper palliative care or proper decision making put in place. So I don't think we can draw conclusions from single cases. What we can know is that the Oregon legislation really only relates to a less than 1% So is that a significant number, as Bob puts it? Well, not on a statistical basis, it's not if we take p-values as being relevant. And then what is the number needed to harm or the potential risk in order to change the position that we have as a profession? And I would argue the risks far outweigh the benefit, not because the slippery slope, because the slippery slope is an interesting argument. If you ask, it's slippery in that once you step across or step over the cliff, as Karen describes, you can actually just keep falling, but you don't actually have a slippery slope. What happens is that the people who ask for changes to legislation just grows. So your halfway house, as you put it, is what everybody says, oh, well, there's never any slippery slope. But that's because it is only a halfway house. So if we're going to go the full house, then there's your slippery slope. So I think the slippery slope argument is clever language. And I agree that it's about legislation change. So I think the number needed to treat is not justifiable to the risks that are associated with this.
So
okay,
Tony,
yes, I will bring you in, and I'll bring you in just to off the back of it, because we've got someone who made a relevant comment here. It's from John Smith. I don't know if this is true or not, but it's come from the audience. Overall suicide rates in Oregon among adults rose approximately 50%, 41% higher than the national average between 2000 and 2010. The legalisation of assisted suicide in 1997 has undoubtedly normalised suicide to an extent. How can the medical profession countenance normalising suicide? So that's an added issue alongside the Oregon issues, which no doubt you're about to discuss.
Well, I think language and the difficulties with language come in here. Many of you will recall a famous quote from Wittgenstein, who said, we can be bewitched by language. And when you use the bald word suicide, what do we think of? We think of the 18-year-old boy committing suicide, we think of someone throwing themselves off the Gap in Sydney, etc., etc. And we have an immediate association with mental disorder. No one's going to pretend that the vast proportion of suicides that occur in all our countries are related to mental disorder. Rodney Syme, amongst others, has recommended that we stop using the word suicide and we use, as we are in this session, use the phrase assisted dying, because suicide brings up these connotations over which there's a very strong consensus. So I'm not sure about the figures that are quoted there from Oregon. I can't make a comment on that.
Yeah, and more broadly, the issue that we were discussing earlier.
You mean the distinction between physician-assisted suicide and voluntary euthanasia, as in the case of the lethal injection? What we were discussing earlier was the fact that if legislation goes through in any jurisdiction in Australia, like Oregon and the other US states that have legislated, it's more likely to go through on a sort of pragmatic political basis if it's similar to that model. Because we all, I think, have an intuition that it's a little bit more serious, and some would say a whole lot more serious, to give someone a lethal injection compared with giving them a prescription. And we talked about this earlier in the session, where I agreed with Karen that I don't see any moral distinction between those two actions at all. But on a purely pragmatic basis, it is likely
I forgot
that will
myself for a
happen.
moment there, but of course the question that we were addressing before we digress a little bit was about whether palliative care in fact is the answer and whether it can solve all problems.
Well, as we've heard, there are some palliative care physicians who concede readily that palliative care can't help everybody. Bob Dent, the first person who availed himself of the Northern Territory legislation back in the mid-1990s, was offered palliative care, had some palliative care, and decided competently that that was not for him. And it goes to what Mark was talking about before, where he said, well, we can kill the patient or we can offer them treatment and support and so on. And I think the problem here is that palliative care and assisted dying are seen as alternatives. I think that's a crucial conceptual and practical mistake. if you look at Belgium, you can see in practice the compatibility of the two concepts in the two areas, where assisted dying in a very small number of proportion of cases is part of the palliative care system in Belgium.
I'll just quickly go to some more questions from the floor. Go ahead, sir.
Thank you. My name's Dr. Sean Rudd. I'm a general practitioner in a nice little place called Harvey Bay in Queensland, which is known as the place where there are the newlyweds and the nearly deads. And the reason for that is it's also Australia's nursing home, basically.
There, would you?
No. That's right. You would never get another partner because there are no 40-year-olds there. So it's true.
All right.
A little Harvey Bay joke between the two of us. We'll move on.
Just to move things on to a slightly different place, and the reason I said that with Harvey Bay was that we have 7 nursing homes within a few square kilometres, and I'm lucky enough to go around those nursing homes. And the thing that I struggle with on a daily basis when I'm in any nursing home is the patients who can't say anything, the patients who are lying in the bed, who, as Richard said, are pooing and peeing themselves, the patients who are unable to communicate, the patients who look to me like they're inside that head they are suffering. But I don't know the answer to that question. So, like most things in life, I always like to get some help from someone. So I'd like the panel to help me in some way work out, am I just being weak by not helping those people, by not doing something active to stop them dying, or doing inactive things like, it sounds a bit crude, but putting food within reach and seeing if they can reach it. But, it's really difficult to see those people, and I feel a bit weak when I walk away and just leave them lying there. So I'd be interested to know what the panel thinks about that group of people.
Well, we'll start with Karen on that.
I think it's really difficult. Look, I think that the way that we treat our elderly and disabled citizens is pretty poor. I mean, nursing homes are, on the whole, there's some really great ones, but they're on the whole purpose designed to accelerate neurodegenerative decline. I think that when we look at people who have stopped talking or...
I presume you mean accidentally designed in that manner?
Well, I'm not sure. They're based on hospitals, and they're certainly not places that... Look, there was a parliamentary inquiry about a year ago or something in, I don't know if it was in Victoria or nationwide, into young people, young disabled people who were being forced to live in aged care facilities because there was no alternative. And the newspapers were full of stories full of outrage, people saying, my daughter, she's 50 years old and she has to live in these places with all these old people, and she can't decide when she goes to the toilet, she can't decide when she goes outside, she never goes outside, no one visits her, she's not allowed to choose what she has to eat. It's outrageous. And everyone said, we need to do something about this and improve the lot of these people. But it was like this enormous blind spot. I mean, why is that okay when you turn 65? I mean, it was just crazy. I don't know what to say. Each of those scenarios that you describe, they're all individuals, and they all have different stories and different family situations. And in the hospital, people from nursing homes, some with very advanced dementia, come to the hospital for treatment of pneumonia, and sometimes they come because their family really values them, even though they seem that they can't communicate. And so we would treat that patient because that patient has a place in society and a life that is considered valuable by people around them. Some people come in and they've got an advance directive that says they don't want to come to hospital, so we dutifully look at everything that's happening, and probably they'll go back to the nursing home with comfort measures. I mean, I don't think as a GP going into a nursing home, you look at those patients or those residents, those people, and you think they're suffering. I mean, we don't know. How do you know?
Go back to our questioner. Sorry to interrupt you, Karen. Quickly go back to our questioner. Just go to the microphone again, if you wouldn't mind. Are you just to get to the nub of your question? Are you wondering whether it would be more humane to hasten the death of some of these people?
Well, I think it goes back to what you would feel yourself, your own values, and my parents are both dead now. But I mean, they clearly stated to me that no way would I allow them to be in that situation, and I think there's no way that I want to be in that situation, and I think that's an important view. But however, I'm still too weak to do anything about it, and that's why I'm wanting help people to.
Let's go to
does that
Mark,
make sense?
Yeah, absolutely. Go to Mark.
Can I try and answer some of this? Because as a geriatrician, obviously, I mean, this is commonplace. I think it's important to remember that dementia very rarely kills anyone. People very rarely die because of their dementia. They die of a complication as a result of neurodegeneration. So they die of a swallowing problem and pneumonia, etc. So the first thing I think is important to make sure that when you've got a patient of this sort, that there is some clear advanced care plan and the family understand and are clear with you about what's going to happen. Because remember, the only people who really are suffering here are potentially the family, because they're the ones who will live with the grief if it hasn't been well managed. And it's about the management of that. So can you judge whether the person is suffering or not? Well, I think we can. There are very good pain, non-verbal pain measures now. There's the AB pain score, and you can ask nursing staff about grimacing and other things when there's movement. And, you know, the fact that we as a community value, or we provide a value for people who are living and we support that, I think that's very important. And this is the very reason why I don't think we can afford to step across the precipice. Having said that, the population with dementia is very interesting. And I put up a hypothetical quite recently in my hospital where we had a lady who had a dementia, profound dementia, but she was very happy in her dementia-specific nursing home managing and caring for the therapy dolls, and she had acquired a relationship with another man with dementia, and they sat basically hand in hand folding towels, and that was a life. Now, the question is that the family had said, well, if I didn't want mum ever to live, or she had said before, 8 years previously, that, well, I didn't want to live if I couldn't recognise family. So we come back to this very complex question, which I've put to people like Julian Savulescu. So when is a body, how do we define suffering? And I don't think we know. So I think the easy end is physical deterioration, and then you're very close to death, because in dementia, that death will occur. But we shouldn't be treating the pneumonia. We shouldn't be treating a stroke event, because these are the causes of death in dementia in the terminal phases.
Mark, you're obviously quite right in saying, as you said earlier, that with cases like this, the law changes, particularly if you like the halfway house ones, as you put it, as I put it, I guess, and you obviously jumped on. They would have no effect at all on cases like this, would they? That seems to be the main point, and these would be the largest body of people going into end-of-life phase.
Yeah, I think that's the thing that concerns me. You know, we're having all this debate as a profession about a very small group of people, but it's GPs who have to actually. If this legislation was passed in Belgium and in Netherlands, it's the GPs who get asked all the questions, and yet it doesn't help you with the very population you need most of the help with. And so that's why I think our focus, if we take a public health measure, and Bob's a public health physician, the biggest bang for our buck, if we're going to invest any time and energy as a profession, is getting palliative care right, not worrying about what's happening in this particular end.
Let me bring in Georgie here briefly, and I'm not sure if your study has gone that deep, but do any of these particular sets of laws in Belgium, in the Netherlands, in Switzerland, maybe in Canada, certainly not in the other places, do they deal with this issue?
Of vulnerable people? Well,
Yeah.
I think that some of the legislation does allow involuntary euthanasia, I think. I have to confess I didn't go into the detail, and I'm sure the others on the panel will know this, but so there are some jurisdictions that do, but certainly the Oregon and Canada are all about competent adults making a request.
Yeah.
Yep.
So, Bob, what do you think about this? Does it change your position at all? Does it make you think, or do you think that there just needs to be a sort of segments of the unwell community who are treated differently?
I don't think this debate about euthanasia bears closely on the question, because I think that is a bigger and broader question. I do think that a lot of the debate, and I'm sure Mark would agree with this, has been generated because people are concerned about what is happening in our nursing homes, and are concerned about the fact that, and I'm concerned. I don't want to die in a nursing home. I would like to have the possibility of a parcel of Nembutal available if in fact I get to the point of recognising for sure that I'm developing Alzheimer's. And I would have no hesitation in using it at that point. Now, it seems to me that that's the point that we should be respecting autonomy. Mark laughed at autonomy. I think we are autonomous creatures. We make decisions about our everyday life every moment. And I think we have to respect the concerns that a lot of people have about what precisely the question's been asked. But there's no way we could have physician-assisted suicide quietly dealing with the problem. But I do think that the possibility of reassuring the community that they have a degree of autonomy over the future. Now, I think Marshal Perron, who was responsible for the Northern Territory legislation, who was part of our round table, put it rather nicely. He said, the law currently says to us, if you get towards the end of your life and the existential situation is impossible, you can go out and commit suicide, that's all right, we don't want you to. But it is, you're allowed to shoot yourself or hang yourself from the ceiling fan. But wouldn't it be better if you could, when you reached that point, know that you could have that terminal event with your family and the loved ones and the tears and so on around you and die with dignity rather than go and shoot yourself?
I'm going to bring in the next questioner because we've got if you would like to try and get to all of them. Thank you very much. Yes, you can.
I think I'm like an asylum seeker. I didn't put the name of my question. This meeting has been doctors associated with assisted suicide and euthanasia. You seem to be thinking you're working by yourselves, because I've worked in palliative care for 20 years and never has it been just the doctor who's the one to bring peace, whether you call it existential or pastoral care. They are very important. So you're talking about people as if they're dogs or your pet cat or your pet horse. You're not thinking of anything more than the body. And you're thinking about your family, sure. But there's much more to it, to the person. And I'm just wondering why we're just so stuck in the AMA. I'm a member of AMA and I appreciate it. But when you're talking about the dying, you've got to think more than the person, the patient. It's the family and it's their inner spirit. And I'm just wondering why we're just stuck there. You're not talking about the person who with pastoral care, help from other people, can really get through the depression, Bob. I know, and I've met Professor Maddox. He was in Korea when I was there. And we didn't have a round tables discussion, but I was introducing him to one of the other universities to get palliative care going. So my question is, can we not increase the talk? Apart from doctors only, it's doctors and staff, nurses and pastoral care.
And patients?
And the patients, that's the
okay.
prime one.
Let's hear from Malcolm first.
I'll be very brief. I couldn't agree with you more, and I would imagine everyone would agree with you, but I don't think that makes or helps or demonstrates any kind of moral distinction between active assistance to die on the one hand and on the other hand withdrawal of life-sustaining treatment, which is one of the sort of the fundamental principles that we have, as I said earlier, in the past stumbled over and perhaps not really moved forward with. So I couldn't agree more with you, but I don't think it helps the actual debate around that distinction.
I actually think that that's exactly the crux of the matter, what you've just brought up, because a good functioning palliative care team is composed of many, many different clinical specialties: doctors, nurses, psychologists, social workers, grief counsellors, etc., and it involves the entire family. And what we are proposing here is that instead of that, a doctor can give a script to a patient and they can go home alone, or to their perfect family that always seems to be described as existing, because everyone's family is always perfect in the media, loving, supportive, especially if the person's dead, so you can't actually ask them. But I think that's exactly the point, that we're replacing that whole team of individuals, not just the doctor, because really, on my ward, the most important person is the social worker by far. The drugs are pretty useless. But we're going to replace that with a script for whatever.
Okay, I think Bob should get a chance to respond, since you were, part of the question was directed to you.
Well, yeah. The reason I think we're having this debate here is because this is the AMA, and the AMA has taken a very strong line on this and has probably been highly influential in the fact that we've had 51 attempts to enact legislation in Australia, and none of them have succeeded except the one that Marshal Perron initiated in the Northern Territory. So, look, I totally agree about what's been said about palliative care and about whole person care and multi people involved. What has happened, and the reason why I regard this as a very important venue, is that I do think that the medical profession through its AMA has been highly influential. And it's interesting that what has happened in Canada, and we haven't talked about that, but Canada is moving now to legislate, and the lawyers have helped to make, or the judges have helped to make this happen.
Well, in fact, you're right. It was a Supreme Court decision based on a test case, and they resolved that a person who, I think it was with a serious debilitating illness, in fact, George, you'll be able to tell me the details, that it was too cruel to stop them having the opportunity to end their lives. That was essentially the nub of the decision.
And the bottom line is that assisted suicide will become legal in Canada if it hasn't become legal already. I think it's in June. The point about that I want to make is that the Canadians really acted, the Canadian Medical Association has acted with extraordinary responsibility on this and has put out a magnificent document that is guidance for doctors and is guidance for legislators as they move to put in place legislation to make this firmer. I think it is not that the medical profession in Canada is taking a firm line one way or another. It is simply saying, this is the fact. This is going to happen. Now, if it's going to happen, this is what we need to do. And I would urge the AMA to develop a document very similar to the one that the Canadian Medical Association
probably would require a High Court case. Their Supreme Court directed the laws had to be written. Georgie, you can just perhaps give us a better legal description of that.
It's quite interesting actually to look at the Canadian decision. It is heavily based on the fact that I think that the Canadians have a Charter of Rights and Freedoms, so they analyse their laws in that context, which is different from us. And Malcolm and I were talking about it earlier actually. I can't imagine our High Court giving a decision like this, and they usually what they do is give a decision that says, well, it's not our role, it's up to the Parliament to make decisions in this area, rather than, as you say, Tony, essentially directing the court that they were saying it was the provision against or the law that says that it's illegal to assist suicide as a practitioner is contrary to their Charter of Rights and Freedoms. And
breach the human right of that particular test case patient.
That's right. The patient had ALS, which I think a lot of the test cases in Canada seem to have patients with that sort of neurodegenerative situation.
Mark.
Which is what happened in the UK. So the House of Lords said this is a parliamentary decision. It went back to the Parliament and failed. And that's what happened in Scotland. It went back to the Parliament in Scotland and failed. detailed, careful thought, large, very substantial reviews, decided that in the context of the English situation, in the context of the Scottish situation, it wasn't going to work. There is no move at a High Court level in Australia that we should change our position. We as a profession have the opportunity to try and to lead in to that. And if in fact the reason, Bob, you will choose to euthanize yourself is because our nursing home environment is so abhorrent that we're not prepared to we look after our elderly so badly that in fact I'd rather commit suicide or be euthanized than go to a nursing home. Let's fix our nursing homes.
Yes, yes.
Oh, that would be good. Yeah, sorry, Bob. You can jump in and we'll just go to our next question after that.
It's not because I think the nursing home situation is appalling. It's because at that point I would feel I was in a position to decide that it was time to end my life. It's not... I think to sort of say we can fix this by simply making the nursing homes a little bit better is not really the answer to the concerns that a lot of people at my
Sounds like,
stage have.
Bob, in political terms, you might have to begin by campaigning for a Bill of Rights if our Parliament's incapable of dealing with individual rights.
Well, can I just say one thing? I'm sorry, but we seem to be developing this absolute horror of needing care and assistance. And so, you know, we're all upper middle class, very well educated, powerful people who've had control over every aspect of our life, unlike the majority of the population. And the idea that somebody might have to help us go to the toilet or that we might drool or get crumbs in our cardigan is somehow horrific to us, or that we might not be able to absolutely be in control of everything. And it's horrific to me as well. But the thing is that if needing care and assistance is horrific, what does that say to people who need care and assistance? I mean, if we say that it's so bad that we should be allowed to get a doctor to kill us, then what about all the disabled people? What about the people who need care and assistance? Like, to care for someone now has become something that's a cost to us, and to need assistance is a horror. And we've lost all of the sense of the mutually enriching and beneficial parts of that relationship.
That's a good argument, but it doesn't cope with the individual choice element of things.
Well,
so should an individual choose to think differently?
Okay.
Are they being penalised by the current laws?
This is the thing that's always interested me about about why progressives are so into euthanasia, because we have choice and we have rights, and I thought that we have a society, not just a group of individuals who happen to be co-located on a chunk of land. I mean, our choices as individuals affect all of society, and I think that if we say that it's okay for some people's life to be considered not worth living, then other people in that situation, the fact that that choice exists actually does have an influence. It's not that every single choice is not influenced by social expectation, by your peers, by circumstance. I mean, choice doesn't actually exist in a vacuum.
Let's hear Malcolm on that choice. Your choice will influence others in perhaps a negative way.
Giving that option it obviously has...
But that option is choice, right?
Well, at the moment there's no choice to ask a doctor to kill you, but if we
change it, then you have the choice.
Yes.
Then that's the point where we're at. So I just want to ask Malcolm about that.
I mean, I think the idea that having a choice and making a choice that someone else may not agree with will influence them to make a choice that they would not otherwise have made can be hugely overstated. We have choice in all sorts of walks of life. Our choices and all sorts of other things influence others. What we do, our actions influence others. This happens all the time. So I don't think that's a reasonable argument to say, well, we've got all this choice, but we won't offer this particular choice. Why not? What's the difference? Of course it'll influence people, but we're influenced all the time.
Yeah, but we're saying that we don't want to be influencing people to feel... all the studies show that the main reason people request physician-assisted suicide is not actually, the majority of people do not request it for pain. They request it because of feelings of worthlessness and hopelessness. So if we give the choice, what I'm saying is if we give the choice, then it will influence people.
I might just make the point in passing that the Oregon laws forbid strictly what you've just said. They give the choice only to people who are classified as being terminally ill with 6 months to live. So you're not quite right about that. But
I wasn't specifically talking about Oregon, and I'm saying people who request, not people who get it. People who request, the overwhelming majority of requests, the reason is I don't even know if that's in Oregon.
It can't be true of the overwhelming majority of requests in Oregon because they have to go.
No, I didn't even
through
mention
that system.
Oregon.
Well, we're just talking about it earlier.
But Rodney Syme would be not happy. I mean, the Oregon legislation does not suit his needs.
Oh, you're right. You're absolutely right.
So
it wouldn't go far enough for many advocates. That's true.
So the point about that issue is still valid. That issue of choice.
The fact is, choice exists in Australia for a certain proportion of people. People who know a palliative care physician who's prepared to play around with this crazy double effect business, and people who have something that can be withdrawn or stopped. And one of the things that came out of our discussions was that this is unequal and unfair. That a certain group of people who know a palliative care physician who does support euthanasia and is prepared to do a Rodney Syme, so to speak, have a benefit that others of us don't. And that the only way to make this real is to legislate in a way that makes this equal for everybody.
Well, you assume it's a benefit to know a Rodney Syme. What if the palliative care team are able to ameliorate the suffering of the patient, but if it's a Rodney Syme, they don't attempt to? I mean, it's not a benefit necessarily.
Okay, so I'm going to interrupt you both. I'm going to give a question to that side of the room because I may have not noticed you standing there for a while. I'll come back to the middle after that. Go ahead.
I haven't been here too long. Louis Christie,
Another queue jumper.
Yeah, another queue jumper. I used to work in emergency medicine and now I work in palliative care, so I've done a fair bit of hanging around death and dying. My question comes about the practicalities, assuming we were to develop a position statement that moves along supporting some sort of physician-assisted something, the practicalities of doing that. So far we've talked about the 18-year-olds and we've talked about the very elderly and infirm. The trouble is not either of those groups so much when we start thinking about the practicalities of doing something. Everyone, or not everyone, but a lot of people in this room like myself are in a situation where we can no longer do what we used to do physically or otherwise 15, 20 years ago. My knee's about to give out. At what point do we take someone who has chronic illness, chronic disability, slow death, slow dying, because, you know, organically speaking, I'm now over about 40, my body's dying more rapidly than it's growing. At what point do we say that person fits in the legislation, that person doesn't? My concern is that the law, when we come down to the nuts and bolts of it, is going to be a very, very imprecise implement, a very blunt implement, to try and create the sort of things that people are hoping to create.
Okay, unless it can be done with precision, and that's a question as to whether it can. So, Georgie, can laws be made with precision?
Well, it depends on the definitions. I was going to get depends in. It depends. I have to give that answer as a lawyer. But yeah, it depends on how it's worded. But always then it's going to be open to interpretation. So that's why you have these, you have submissions and consultations and the like to look at the legislation and the wording. But no piece of legislation is ever perfect. So we've got to remember that as well. But
okay, Bob, and then.
Well, it's worth pointing out that the Swiss don't have legislation at all. They simply say that provided the assistance is done with good intent, the person who assists will not be prosecuted. That's at one extreme. Like you, I'm a bit hesitant about locking ourselves in with a whole lot of laws, but I do think that if we're going to move beyond this stupidity that we have at the moment, we do have to change that especially that double effect thing, and say it is conceivable that a physician may be in a certain circumstance be able to assist his patient to die. That we will publicly decriminalise it. Now we've effectively done it, but it's not fair across the country. Rod Syme's doing it all the time, and publicly saying so, and challenging the prosecutors to take him to court. What we surely need to do is make explicit in law the fact that this is not a criminal act on the part of a doctor to assist his patient in the best interest of that patient.
Okay, Mark.
So, I mean, but the question is, we've now been having debate about euthanasia and legislation of euthanasia since the Northern Territory, 20 years. We've practiced medicine as a profession very successfully with maybe there's a couple of high-profile public issues. And we've done that within the existing legislation very successfully without having to actually undermine 2,000 years of our basic ethical principles about life. So I come back to the same argument. I think Rodney Syme wants to have a fight. Why do we need one?
Let me just quickly raise something with you. It came up in some research that was thrown our way, the ABC, but one of the big questions is whether many doctors are already intentionally hastening the deaths of terminally ill patients. And a survey in 1999 of 683 Australian surgeons showed that 36% of them admitted they had administered drugs in greater than the amounts required with the intention of hastening death. 23% of those surgeons said they did so without consulting the patient. So is it already happening, and is that part of the reason why it needs to be codified in law?
Well, I think that depends on where you see ourselves as a profession. I mean, we have a very strong ethic. We have legislation such as in Queensland which says we can manage the double effect so long as it's consistent with good clinical practice. It's a very strong piece of legislation. I've seen Joanna here, so she could speak to our current medical board, Australian Medical Board ethic, and this has not been challenged, and it's not challenged because in fact there's good communication with families, there's shared endeavour, there's shared thinking about how to deal with an issue, and we deal with it. We're doing that without having to fundamentally undermine basic professional ethic. And I think as a professional, as a doctor, if I don't have to go home every night worrying about have I actually made this right decision, dwelling on those issues, I don't think I'm doing my job. And I think we want to sterilise everything we do. We want to sterilise death because we want to make it so clean and the lawyers get involved. Then it's no longer, it's just so we don't have to think about it again. I think that's a real mistake because what it'll do is undermine what we are, which is a profession.
Tony, can I just make one short point in response to the previous question? In essence, the question was about where do we draw the line? That's a scope question. Who falls into the category who will qualify for assisted dying should the legislation be introduced? As Tony indicated earlier, Oregon has put very heavy dark lines around the boundary. Terminal illness, 6 months to live, prognosis and so on. So there are scope questions there clearly. One of the essential features of the law, whichever a category of the law you look at, lines have to be drawn which cannot be that good. They're often always fuzzy. Think of negligence litigation. Think of all sorts of different areas where judgments are made not on a numerical basis, but it's a judgment. So I don't think that argument, and I'm not suggesting you're putting this argument against legislation, but I don't think that if it is put as an argument, oh, we can't draw lines, we can't circumscribe things adequately, so we shouldn't have it. I don't think that runs.
Okay, let's try and get through these questions. The people have been patiently lined up here. We've got 3 of them. We haven't got a lot of time, so I might just go to individuals or 1 or 2 people. Go ahead.
Thank goodness I was about to request euthanasia. Michael Glixman, I'm a physician, but I'm going to come at this as a patient. About 6 to 8 months ago at a major Sydney hospital where I'm well known, for positive reasons I hope, I ended up in accident and emergency. I was convinced what I had was an SVT that was recalcitrant and dropped my blood pressure through my boots. But the moment the staff saw me, there was panic. You don't go to hospital if you're reasonably well known there. And the diagnosis was cardiogenic shock. Eventually their panic was infectious and I started to think maybe they're right. My family came in, I said my goodbyes to them and it reverted. What that taught me was that I was not afraid to die, not at all, but I am really concerned about the manner of that death. And as a doctor, and as every doctor here, I have the choice as to how I'm going to die. I'm not going to ask you to commit suicide if you don't want. You don't have to euthanize yourself. But I can, and every doctor here can make that choice. The only people who are denied are our patients. And I think that is indefensible. And sorry, that's a statement. It's a rhetorical question.
But it's one worth getting a response to. So, Karen, it has come up time and time again. Doctors can do it, patients can't.
Well, yes, they can. I don't understand why you said...
Well, not unless they illegally get access to
themselves.
Yeah.
What knowledge do they have
to do it? Well, then why do we have such high suicide rates? I mean, look, so we can do that ourselves. I just don't think that's an argument for meaning that everyone should be able to have access to drugs.
I think it is an argument, and it's not everyone. There are strict limits to it. It works in other countries.
Well, who should
make your choice?
Who should? You make your choice. Well,
no, you make your choice. But to make it for others when you can make your own choice, I think is pretty offensive.
Anyone can come to you and ask for the drug.
I think I just mentioned under strict legislative guidelines, as is done overseas.
And who will decide what?
We can't do what we just can't take our own.
Hang on, he's asking questions. We can't be cross-examining him. No, I'm not. You don't have to be sorry. You're being cross-examined by our panel. Mark.
But that's all right. I can return it just as well because there's a tremendous amount of hypocrisy going on.
I think this is. I think that's completely wrong. I'm a geriatrician, so what am I going to get access to? I mean, I can't just go and prescribe myself propofol. I can't go and just prescribe myself morphine.
You don't know the combination of drugs you can prescribe and get a hold of.
But I mean, that's
kill
all
yourself. You're a very ignorant physician.
Well, thank you for that.
You're welcome.
And I'm very pleased that I don't actually have that skill set our palliative care physicians have. But this argument is like saying, oh, well, you doctors can do it and you're not going to allow the rest of the community to do it. I think that's a senseless argument.
But at a broader level, the argument beyond whether you can prescribe or not prescribe for yourself, the argument is, do you get to make decisions for individual patients? So bring in Bob, because he has a very different view to you.
Well, I think I've expressed it already. I do think that the patient needs to have control over their time of dying and their kind of dying. We have taken that from them, except for a rather small proportion of people, including doctors, and Mark kids himself if he doesn't know how he could kill himself, very, very painlessly and very easily. We've taken that away from the community and said, well, we'll keep it in the hands of the profession who will use this silly double effect business.
We haven't taken anything away from the community. What have we taken away? We haven't taken... We haven't taken away... Never in history have human beings been able to choose when they live, when they die.
The manner of that death we have taken away from them. We have taken the choice as to the manner.
Did they have it before? They didn't have it before. What we think now, we can control everything else in our life so that we should be able to demand a caesarean section death now as well. Is that our right?
Drugs which were not prescription drugs are now prescription drugs. We have taken that right.
Most people in the world, I just want to say one thing, most people don't actually have choice over many, many aspects of their life. That some people don't have somewhere to live, some people don't have the choice of a job, some people don't have the choice of dinner for that night.
That's okay.
And that's completely outrageous.
Yes.
But I just think maybe you just don't have the choice to die cleanly and exactly when you want. Maybe we just don't.
We do have that choice. It's been taken away.
Okay, I'm going to leave that there. There's an interesting balance of arguments. I'm sorry to our other questioners, because I was told when Michael Gannon loomed above me like the Grim Reaper, that'd be time to stop the questions, and there he is, lo and behold.
Oh, thanks for nothing, Tony. Can I...
Metaphorically speaking.
Metaphorically. Can I please start by asking you all to thank Tony Jones for his outstanding professional job. I think this is about my 12th national conference. I cannot remember a more interesting, more engaging session. I think that was absolutely fantastic. I'd like you to thank the panellists, Professor Bob Douglas, Ms. Georgie Haysom, Dr. Karen Hitchcock, Professor Malcolm Parker, and Associate Professor Mark Yates. Absolutely fantastic. I'd like to thank you, the audience, my colleagues, for your participation. I do apologise that there were a number of people who put a lot of effort into submitting questions that were pre-selected. We gave, I can get back at Tony now, we gave him freedom to let the session go in the appropriate direction. I also apologise to those people who were stood up for some period of time and others that would have stood up. That session went for nearly 2 hours, twice the length of the television program. Fantastic content and a lot of work ahead for the Ethics and Medico-Legal Committee and the Federal Council. Any questions about AMA policy or the review process can be forwarded to the email address ethics@ama.com.au. And we will continue to keep members informed of the process. I really hope you enjoyed the session. Thank you for your participation.